Hi, this is Dr. Perry Carpenter. I'd like to thank you for joining me on today's program. Today's program is from the Special Population Series, and today's program is entitled Exercise Prescriptions for Orthopedic Injury and Rehabilitation Clients, or in our case, we could refer to those as chiropractic patients. I have a fascinating program for you today, and it's a program that I'm sure will provide invaluable information for you as you handle your chiropractic patients that have specific conditions that require your help in the rehabilitation of those conditions. And let me just take a moment to introduce myself to you. This is Dr. Perry Carpenter. I'm a chiropractor. Been a chiropractor for approximately 28 years now. I graduated from Palmer West College of Chiropractic. And throughout the years, I've taken many different types of continuing education courses. And I list for you here some of the courses that I've completed that qualify me to speak on today's topic. And specifically, I'm going to be making extra reference today to materials derived from the National Strength and Conditioning Association, of which I'm a member. I hold two credentials with the NSCA. I hold the Certified Strength and Conditioning Specialist credential and also the Certified Special Population Specialist credential. And today's material is largely based on ideas, references, and concepts about rehabilitating and treating persons who qualify as special populations. And today we're talking about that group of special populations that we find in the chiropractic practice, and that is people who have healthcare issues. Specifically, today we're talking about injuries and issues with the musculoskeletal condition. So today's program is about injury, orthopedic, and rehabilitation patients. And those certainly qualify as special populations. And those are certainly people that have special and unique needs perfectly suited to the work that we do as chiropractors. So I'm going to be supplementing chiropractic material today with additional material derived from the exercise sciences, and I will be quoting some references from the National Strength and Conditioning Association. References for today's program are many, and draw your attention to a couple of textbooks from the National Strength and Conditioning Association. I'll be presenting information from the Essentials of Personal Training and also the Essentials of Strength Training and Conditioning. I'll also draw upon material out of Lippincott's Primary Care Orthopedics 2nd edition. I'll refer to Yoakum and Rowe Essentials of Skeletal Radiology, specifically when we get into a discussion later on the rehabilitation of spondylolisthesis and spondylolysis. I'll be drawing on some physical examination procedures from the Fundamentals of Musculoskeletal Assessment Techniques. That's a fabulous textbook by Palmer and Epler, a couple of physical therapists. I'll make also a brief reference to the AMA Guide's 5th edition, and those of you that are qualified medical evaluators, you'll recognize those references. And then I have a couple of specific references for you relating to the shoulder and the lumbar spine. And I chose and selected these references for a couple of different reasons. Number one is they relate exactly to topics that we're going to be discussing, specifically related to the lumbar spine and specifically related to the shoulder. And also because each of these articles illustrates some general principles that are extremely important principles that we understand regarding injuries and rehabilitation in general. And I'm going to make early references to each of these principles early in the program. And then when it comes time, when we get to the lumbar spine section and when we get to the shoulder section, I will reiterate these principles by drawing upon these references, specifically as relates to the region that we're considering, whether it be the shoulder or the lumbar spine. And I know you're going to find these references to be fascinating, and these are some principles that are illustrated in these references that you can rely on and that you will rely on in your practice from now to forever. Okay, well, what about shoulder instability? I want to spend some time talking about shoulder instability because, as I stated earlier in this program, it's my opinion and it's my experience that we often underdiagnose cases of shoulder instability. And the reason that we fail to recognize shoulder instability is because our examination procedures for the detection of shoulder instability are weak, and we're not attuned to the possibility of the presence of shoulder instability. And so therefore, many of these cases go undetected, they go untreated, and these patients end up with chronic and recurrent shoulder pain conditions. And so I want to spend some time on shoulder instability, and I want to encourage you to improve your examination protocol for shoulder instability and increase your awareness as to at least the potential for shoulder instability to be a primary cause of pain in your shoulder pain cases. Okay, so first of all, let's define shoulder instability, and then we'll get into some of the anatomy involved with shoulder instability. And I'm going to take this definition right out of the AMA guides. I don't know how many of you are familiar with or even have the AMA guides, but the AMA guides provide us several important and relevant passages, at least with regards to shoulder instability. So the AMA Guides 5th edition tell us on page 503 that shoulder instability, recurrent joint subluxation, or dislocation, so that's three things, that's shoulder instability, recurrent joint subluxation, or shoulder dislocation, occurs when the integrity of either the glenoid labrum and or of the surrounding capsulo-ligamentous and musculotendinous structures becomes compromised following either one or more acute traumatic dislocations, repetitive microtrauma, or arthritic conditions. So let's just review that definition. It says when the integrity of the glenoid labrum, of the capsulo-ligamentous structures, and or the musculotendinous structures becomes compromised. And we said earlier in this program with regards to synovial joints that all joints have capsules, all synovial joints have either intracapsular or extracapsular ligaments, and synovial joint stability is contributed, at least part of the stability is contributed by the musculotendinous structures that cross the joint. And we talked about that earlier. So here with regards to shoulder instability, we see true proof of the necessity of proper balance and proper integrity of the bony structures, of the articular surface structures, the capsulo-ligamentous structures, and the musculotendinous structures. And compromise to any one or any combination of those structures will compromise the stability of the shoulder joint, which in and of itself is an unstable joint by virtue of the fact of its great mobility. So let's talk about the capsule and the capsulo-ligamentous structures. So with regards to the glenohumeral joint and the glenohumeral joint capsule, we see that the joint capsule is reinforced anteriorly by three ligaments, and these are referred to as the glenohumeral ligaments. So we have the superior glenohumeral ligament, we have the middle glenohumeral ligament, and we have the inferior glenohumeral ligament. And all of these ligaments are simply thickenings of the joint capsule. So these are extracapsular ligaments that are inseparable and are contiguous with the capsule itself. So they're extracapsular, but they are continuous and contiguous with the capsule itself. And the capsule is also strengthened anteriorly by tendons of the pectoralis major and also the teres major. So these are going to be some important musculotendinous structures that provide for stability, at least anteriorly, of the glenohumeral joint. So here's a diagram, and it shows each of these capsular thickenings. I'll bring out my pointer. So here's the glenohumeral joint. Here's the subacromial arch. And this is the synovial joint capsule. This is all fibrous connective tissue that's reinforced by local thickenings here with the superior glenohumeral ligament, the middle glenohumeral ligament, and then the inferior glenohumeral ligament, which wraps around and slightly posteriorly towards the back of the glenohumeral joint. So these are all simply thickenings of the articular capsule of the glenohumeral joint. And this is an area of potential weakness where the shoulder can either dislocate, can subluxate, or can become recurrently unstable in the anterior direction. Here's another series of diagrams that show the glenohumeral ligaments. This is from the lateral view. This is toward anterior here, and this is toward the posterior here. Shows the superior glenohumeral ligament, the middle glenohumeral ligament, and then the inferior glenohumeral ligament, which wraps around slightly posteriorly around the posterior inferior aspect of the glenohumeral joint. So again, here they are, superior, middle, and inferior glenohumeral ligaments. And these are showing the ligaments with the capsule removed. So we get an indication of where these ligaments lie with respect to each other. So notice this provides only minimum resistance to anterior movement of the head of the humerus within the glenoid cavity. Now, the AMA guides continue to expand upon shoulder instability, and they tell us that predisposing factors to shoulder instability can include, number one, abnormal contour of the joint itself from either congenital or post-traumatic origins. Number two, congenital laxity of the capsulo-ligamentous structures. Or number three, musculotendinous. And the guides tell us that instability is the inability to maintain a normal relationship between the head of the humerus and the glenoid fossa, and can be manifested by pain and muscular defense, which is induced by provocative movements in the direction of the instability. And this is going to form the basis of our physical examination maneuvers. When we perform our physical examination maneuvers, we attempt to provoke the glenohumeral joint in the direction of the instability. And for the purposes of this section of this program, we want to focus on anterior instability of the shoulder, because that's the direction of most common subluxation. So with our physical examination maneuvers, we attempt to provoke instability. And in the presence of bona fide instability, these maneuvers will provoke pain, and they will provoke muscular defense to prevent subluxation or dislocation in the direction of the instability. So these are what we want to look for on our physical examination maneuvers. Particularly, we want to look for the involuntary reflexive action, which the AMA guides define as the muscular defense. So we'll get into some of these physical examination maneuvers as we go. In general, our physical exam for shoulder instability is going to include range of motion measurements. It's going to include tests for the assessment of the laxity of the capsulo-ligamentous structures. And then it's going to also include provocative tests which attempt to sublux or dislocate the shoulder joint. Now, to be considered truly positive, the examination maneuvers must reproduce the examinee's symptoms, which is reproduce the examinee's pain. The examination maneuvers also need to provide us with the involuntary muscular defense in order to constitute the true positive objective finding. And this is something that I did not realize or recognize in the early phases of my career and in the early cases that I was confronted with in my chiropractic practice. I was not sensitized and I was not educated on the importance of the muscular defense. We'll talk a little bit more about muscular defense as a true objective physical examination. So some of the tests that we use for the assessment of shoulder instability include the sulcus sign, which is one of the laxity tests. We use the loading anterior and posterior drawer test. We use the apprehension test, which was the one singular test that I learned in chiropractic school. We use the Job's anterior relocation test as a validity maneuver for the apprehension test. And then there are some additional tests, such as the fulcrum test and the labral clung test. So let's go over these tests. With the sulcus sign test, the sulcus sign is used for the assessment of inferior laxity of the glenohumeral joint. Now, the sulcus sign can be noted with or without applied traction down the axis of the humerus bone. If the sulcus sign is noted without applied traction, then that indicates a more lax shoulder joint capsule. Sometimes the sulcus sign has to be evoked or reproduced by applying traction down the humerus bone. So in order to assess for laxity of the capsule and the ligamentous structures, you simply apply traction to the humerus bone while the arm is relaxed and at rest at the examinee's side. Inferior translation of 1 to 2 centimeters is suggestive of inferior instability. On inspection, you will notice a dimpling of the skin below the anterolateral acromion, and this is what we refer to as the sulcus sign. This is the sulcus sign. Now, even though the sulcus sign may manifest itself and may present itself, it's not considered to be a positive finding unless it reproduces symptoms. So what kind of symptoms? Well, number one, pain in the examinee, and number two, muscular defense to counteract the applied traction and to counteract the attempt to sublux or dislocate the shoulder inferior. So here's some photos of a couple actual patients. The one on the left, this shows here some dimpling of the skin underneath the anterolateral acromion. You'll notice that this is the acromion process. Here's the coracoid process. And then this is the dimpling of the skin as the skin is drawn interiorward as the head of the humerus subluxes inferiorly. And you'll notice here, this is a bulge in the skin that represents the position of the head of the humerus. On the right here, we have an examinee that shows at least 2 centimeters of inferior translation of the head of the humerus underneath the acromion process. So this is indicative of inferior laxity with the shoulder even at rest and without applying. Now, most orthopedic texts, including the AMA guides, will describe several physical examination maneuvers for the assessment of shoulder instability. And I want to talk about a couple of those tests now here in this section. So let's begin with the loading posterior anterior drawer sign. Now, we're going to see that different texts describe this maneuver differently. The AMA guides describe this maneuver as being performed with the examinee supine, but this maneuver can also be performed with the examinee either standing or seated. So in order to perform the loading posterior and anterior drawer sign for the assessment of shoulder instability, the examinee is supine, and the shoulder, meaning the glenohumeral joint, is maintained in neutral rotation, neither internal rotation nor external rotation. We take the shoulder and we position it in 60 degrees of abduction and 30 degrees of shoulder flexion. So the arm is sort of positioned obliquely out to the side of the patient. With one hand, the doctor stabilizes the extremity in neutral rotation, while the other hand applies a posteriorly directed force in an attempt to sublux the shoulder posteriorly. So let's talk about this. The doctor simply positions his hand, his opposite hand, over the head of the humerus in an attempt to shove or push the head of the humerus posteriorly in the glenoid fossa. To assess for anterior laxity, you simply reverse the direction of your hands and apply an anteriorly directed force. And it's important to apply these forces in straight vectors anteriorly and posteriorly. Otherwise, we get findings that correlate for different directions of instability. Okay, now according to Lippincot's Primary Care Orthopedics, the maneuver is performed with the examinee either sitting or standing. And the doctor grabs the proximal humerus and applies a gentle compressive force into the glenoid fossa. The purpose of this is to slacken the capsule and to slacken the glenohumeral ligaments. Simultaneously, the free hand supports the elbow, and then using the superior hand, the doctor simply translates the humeral head both anteriorly and posteriorly, attempting to sublux the head of the humerus over the glenoid rim as far as possible. Now, with this maneuver, with anterior instability, as the doctor applies an anteriorly directed force, the head of the humerus will sublux medially in relation to the glenoid fossa. And this is indicative of subluxation of the head of the humerus and anterior glenohumeral joint instability. Now, it's important that these maneuvers reproduce the patient's symptoms, because we can have laxity and physical examination findings for pain and patient reports of pain, but it's the reproduction of pain along with the muscular defense that is key to establishing the diagnosis of either unidirectional or multidirectional instability. And when this maneuver is positive for pain and when this maneuver is positive for muscular defense, it has a 100% specificity, meaning that in patients who actually have bona fide anterior or posterior instability, 100% of them will respond with pain and muscular defense in relationship to this physical examination. Let's talk about the apprehension sign. And I mentioned the apprehension sign because when I was going through chiropractic school and later on in some of my orthopedics courses, we were taught the apprehension sign. But I have to be honest, I never really gave much thought or much credence to the apprehension sign. It just seemed like kind of a silly maneuver to me, and not really applicable in real world situations. Well, with further study and research and with more and more experience in dealing with shoulder injury cases, I've come to have a renewed appreciation for the apprehension sign. So let's talk about the apprehension sign and how the apprehension sign is elicited and what the apprehension sign actually represents. So first of all, to perform the apprehension maneuver, we begin with the examinee supine. And this is going to be important to understand these positional placements of the examinee's arm and shoulder and various body parts, because we're going to refer back to these positions when it comes time to discuss our exercise and rehabilitation recommendations. So we begin with the examinee supine. And the anterior apprehension test is performed by applying external rotation to the glenohumeral joint as the shoulder is held in 90 degrees of abduction. So I want you to picture this in your mind. You have the examinee lying flat on the table, supine. You then take the shoulder and abduct the shoulder to 90 degrees of abduction. Once the shoulder's in 90 degrees of abduction, you simply allow the shoulder to fall into external rotation. Now, as the glenohumeral joint goes into external rotation, the inferior glenohumeral ligament becomes slack, and this is where anterior instability can manifest itself, and you will detect this in your examinee. Now, in the presence of bona fide anterior instability, the examinee will unconsciously fear that the humeral head is going to either sublux or dislocate, causing them great pain. And so what the examinee will do is the examinee will provide for you some sort of involuntary, some sort of reflexive, some sort of a withdrawal reflex that the AMA guys refer to as muscular defense against the motion. So it's the muscular defense against the motion that constitutes the true positive objective finding that confirms the diagnosis of anterior instability. Simply, the presence of pain alone is not necessarily a true objective finding for anterior instability. And so you want to pay particular attention to the reaction of the examinee. It's the muscular defense that constitutes the true positive objective finding for this maneuver. Now, according to Lippincot's orthopedics textbook, they tell us that patients with unidirectional instability will typically demonstrate anxiety. And this anxiety is what we consider to represent the apprehension sign. This is the apprehension sign, and it's reflexive, and it's spontaneous, and it's subconscious, and it's basically a form or an example of a withdrawal reflex. And we'll talk about some of the neurology involved with typical withdrawal reflexes in just a couple moments. So a positive test is indicative of anterior instability of the glenohumeral joint, and as we mentioned earlier, has a very high specificity for those cases wherein there is bona fide anterior instability. So let's talk about some of these involuntary responses and involuntary reflexes that represent true positive objective findings. And this is a general principle that you can rely on throughout your physical examination procedures, not just of the shoulder, but really of any region of the body. And we referred to this and alluded to this with regards to the sciatic nerve tension signs. We said that in the presence of bona fide radiculopathy, the examinee will demonstrate some form of a flexor withdrawal reflex, such as bending the knee, and we call that Neary's bowstring sign, such as plantar flexing the ankle with relationship to the Braggart's maneuver, or any other type of a maneuver that attempts to diminish or decrease tension on the sciatic nerve roots. This is an involuntary withdrawal, and it's reflexive. And the apprehension sign in the shoulder, and also the apprehension sign that we see in relationship to patellar instability, these are all reflexive anxiety reactions that are subconscious, and they're spontaneous, and they're reflexive. They're actually forms of the flexor withdrawal response. So let's review the flexor withdrawal response and relate that to the apprehension sign for shoulder instability. So here we have a person walking along barefooted, and he steps on a tack. Well, the stepping on the tack stimulates sensory receptors, pain-sensitive receptors, naked nerve endings in and around the skin, in the dermis of the foot. Well, that pain-sensitive neuron, these naked nerve endings that respond to nociceptive stimuli, fires a barrage of action potentials which are transmitted up the sensory neuron. Now, this looks like this would be in the L5 dermatome, and this would be transmitted up what? This would be transmitted up the deep peroneal nerve, probably, where this sensory neuron enters the spinal cord and forms a synapse with alpha motor neurons that project to the hamstring muscle. The firing and the action potential in this alpha motor neuron causes the hamstring muscle to contract, to withdraw the pressure of the foot against the tack. Okay, so pain stimuli in the periphery causes a central reflex, which causes a reflexive withdrawal of the foot from the painful stimulus. We refer to this as a flexor withdrawal response. And because the hamstrings are innervated multisegmentally, we notice that the sensory neuron makes synapses multisegmentally within the lumbar spine. And alpha motor neuron discharges are released throughout several levels of spinal nerve roots to fully activate the hamstring muscle. So this is a multisegmental flexor withdrawal response. It's a lot like what happens when you touch your finger to a hot stove. When you touch your finger to a hot stove, the same phenomenon happens. Sensory neurons are excited, and sensory neurons synapse in the spinal cord on alpha motor neurons that activate the biceps muscles and the posterior deltoid muscles and the brachioradialis muscles and the entire flexor system of the upper extremity withdraws your finger reflexively and instantaneously and unconsciously from that hot stove. It's a reflexive response. It's a response to pain and potential tissue damage. It's a good thing you don't have to think about it. Well, the flexor withdrawal response and the crossed extensor reflex and these other types of automatic reflexes are just that. They're reflexive. And some of our physical examination findings are exactly analogous to these types of reflexes, because many of our physical examination maneuvers are designed to provoke pain and designed to provoke or at least simulate injurious conditions or tissue damage, just like stepping on a tack. In other words, stepping on a tack is a pain-productive maneuver, much as many of our physical examination maneuvers are intended to reproduce pain. Well, similarly, the true positive objective finding associated with our physical examination maneuvers, and right now we're talking about the shoulder and anterior instability, is some sort of a flexor withdrawal response. So with regards to shoulder instability, what is the flexor withdrawal response? Well, the AMA guides describe it as muscular defense. The Lippincotts Primary Care Orthopedics describes it as an expression of anxiety. We see this diagrammed in our orthopedic textbooks as what's described as the apprehension sign, the quote-unquote apprehension sign. So you now know what the apprehension sign actually is. It's a reflexive, unconscious reflexive behavior in response to potentially painful and potentially injurious and potentially noxious stimuli, exactly analogous to stepping on a tack. Okay? So in the presence of a positive finding on apprehension testing, we have some confirmatory maneuvers. And you may have heard of Job's relocation maneuver. So we'll just talk about Job's relocation maneuver, and then we'll get on to the exercise recommendations for shoulder instability. Now, the Job's maneuver is performed by applying a posteriorly directed force to the proximal humerus while the shoulder is in 90 degrees of abduction and external rotation. Now, this posterior stabilizing force should reduce the humeral head and relieve any apprehension of anterior instability. So let's imagine this. You have your patient supine and you perform the apprehension maneuver. And indeed, the patient demonstrates the apprehension sign. There's a reflexive withdrawal, there's a look of apprehension, there's anxiety. And to confirm anterior instability, you simply position the patient similarly, or perhaps you may relieve some of the external rotation to a point at which the examinee or your patient is more comfortable, and then you simply apply a posteriorly directed force while reassuming the apprehension position, and the examinee should remain comfortable throughout the maneuver because you've reduced the humeral head and repositioned it back into its proper relationship with the glenoid cavity. Now, according to Lippincotts Orthopedics, they state that relief of apprehension with a posteriorly directed force on the humeral head is a confirmatory test for anterior instability, and they refer to this as the relocation test. Now, the relocation test has a 100% specificity for diagnosing anterior instability in the presence of a positive apprehension sign. So these two tests, when combined, are extremely accurate for identifying anterior instability. What this means is that when you have an examinee who has positive findings on the apprehension maneuver, and those findings are relieved with the relocation maneuver, that's 100% specific for anterior instability. And so it's extremely accurate. And I encourage you to adopt these maneuvers in your normal and routine physical examination of the shoulder, because you're going to be amazed at how many patients will actually provide a positive apprehension sign as you take their shoulder through this sequence of maneuvers. And once you properly diagnose and identify anterior instability, then the proper treatment for that condition can then ensue. In the absence of a proper diagnosis, the treatment efforts are directed at the incorrect problem. There are some other tests that we use to assess for anterior instability, including the fulcrum test and the labral clunk test. And I won't discuss those now, but you can read about those, and you can Google those if you have additional. I'll just mention that the labral clunk test is a test I like quite a bit. It's easy to perform, and in the presence of a clunk or a grating or a clicking or a grinding or some sort of a soft tissue gristling sound that comes from the glenohumeral joint, this is also suggestive of shoulder instability. Not now due to capsulo-ligamentous laxity, but rather due to damage to the glenoid labrum. So I include for you here, for those of you that are interested, I include for you videotapes on each of these physical examination maneuvers so that you can see how that they are performed. For those of you that are watching the PowerPoint presentation, if you simply click this link, this is a live link that takes you to some discussion about shoulder instability testing, where I expand on these discussions in greater detail. If you do not have the PowerPoint presentation, simply bring your cell phone up to the computer screen, and this quick response code here will take you directly to the video. Okay, so let's talk about some of the exercise and rehabilitation recommendations for shoulder instability. Well, certainly we want to avoid any maneuvers that reproduce any of the instability positions. So, for example, we discussed anterior instability as involving 90 degrees of abduction with external rotation as being a high-risk maneuver that reproduces laxity within the glenohumeral joint. So any maneuver that combines external rotation with greater than 90 degrees of abduction or horizontal abduction would be contraindicated. In cases of posterior instability, any maneuver that combines internal rotation with horizontal adduction now, and shoulder flexion would be contraindicated. And then inferior instability would be provoked by full elevation of the arms, such as would be encountered with overhead dumbbell presses, as an example. So this would include, for example, bench presses. If you picture in your mind the bench press position, that involves 90 degrees of shoulder abduction. It involves 90 degrees, well, it involves neutral rotation of the humerus bone. But because of the 90 degrees of abduction and then the anterior stress directed through the glenohumeral joint as the barbell comes down to the chest, that would be a contraindication. Other pressing exercises that involve increasing external rotation, such as incline bench press, such as behind the neck shoulder press, such as behind the neck lat pull down, those would all be contraindicated. There's a machine in the gym known as the pec deck, which involves this exact position. It involves 90 degrees of shoulder abduction, 90 degrees of external rotation, and posterior translation of the arm behind the plane of the body. And this is not the type of exercise that will be kind to shoulder instability. Now, all of these exercises can be modified in some way to make them less stressful to the capsulo-ligamentous structures. For example, with bench pressing, the exercise can be modified by using a narrow grip versus a wider grip. In other words, by keeping the elbows close to the body, you minimize the shoulder abduction and minimize the likelihood of provoking instability. Another idea is to avoid the last 10 to 20 degrees of shoulder extension. In other words, not bringing the barbell all the way down until it touches the chest. And this introduces a weightlifting technique known as strong range partials, wherein only the strongest portion of the range of motion is used. And it's interesting, usually the strongest portion of the range of motion is also the safest part of the range of motion. So if you have a patient who has bona fide shoulder instability, they can still do bench presses and they can still do push-ups, but you simply modify the range of motion to involve the last to include only the top portion of the range of motion. In the old days, we used to call these maneuvers, we used to call them lockouts. Nowadays, they're referred to as strong range partials because they involve partial repetitions performed in the strongest part of the range of motion. So let's go through a couple of examples here. You'll notice that with the behind the neck press, this position exactly reproduces the apprehension test. We have the shoulder at 90 degrees of abduction, and we have the humerus rotated back to 90 degrees of external rotation. And as this bar comes down behind the neck, that causes translation of the elbows further and further behind the body, increasing stress on those anterior glenohumeral ligaments and aggravating anterior instability. Here we have a patient performing the pec deck exercise. Again, notice the shoulder is in 90 degrees of abduction. The humerus bone is in 90 degrees of external rotation. And she's bringing her elbows back to a position behind the plane of her body, increasing stress on the anterior structures here. And in the presence of instability, this is going to be painful and it's going to exacerbate the condition. Now, in patients without anterior instability, these maneuvers are okay, although they are higher risk, and I recommend that the range of motion be modified to avoid the extremes of both of these positions. The extremes of both of these positions. For example, this guy could perform the same maneuver, but he could simply perform the range of motion up in this range only and not bring the elbows so far down. This woman could perform the pec deck exercise, but simply bring the pads no further back than a level of about here and perform partial repetitions in the strongest portion of the range of motion. And that would be a completely safe alternative to an exercise that otherwise carries with it a bit of risk. Here shows an examinee doing push-ups, and you'll notice that the shoulder is in 90 degrees of abduction. Now, this maneuver could be performed in a safer manner by keeping the elbows a little bit closer to the sides of the body, back in this direction here, with less abduction at the shoulder joint. That would be more user-friendly on the shoulder joint. This particular athlete is doing incline barbell presses, and you'll notice that this exactly reproduces, or nearly exactly reproduces, the apprehension maneuver. The shoulder is in 90 degrees of abduction. There's a high degree of external rotation at the shoulder, much higher than would be with standard bench press or even decline press, which angles down in this direction. And so he has abduction, external rotation, and he's bringing the elbows forcibly down behind the plane of the body, increasing anterior stress on the capsuloligamentus structures. And this is going to be contraindicated in those examinees with instability. Okay, so with shoulder instability, what do we do? Well, we want to implement rotator cuff strengthening exercises because, as we said earlier, when the capsuloligamentus structures are compromised and we have loss of structural stability due to laxity of the capsule and laxity of the ligaments, we rely then on the musculotendinous structures that cross the joint to kick in and to compensate, to contribute stability to the joint. So specific rotator cuff strengthening exercises that we diagrammed earlier, especially related to the external rotators, will help to stabilize the glenohumeral joint. Scapular strengthening exercises, such as exercises for the serratus anterior and the lower trapezius muscles, will provide a stable scapula against which the glenohumeral joint can articulate. With stabilization exercise, we want to progress from static stabilization to dynamic stabilization exercises. So an example of excuse me, of the progression of stabilization exercises could involve using either a Bosu ball or a TheraBall, and we would begin with closed kinetic chain exercises and progressing towards open kinetic chain exercises. And we diagrammed some, or we illustrated some open kinetic chain exercises previously by demonstrating a woman sitting on a TheraBall using dumbbells to do some overhead presses. Now, the overhead presses may be contraindicated in shoulder instability cases, but the idea is to progress from unstable surfaces to unstable loads to maximally stimulate and activate the shoulder stabilizing muscles. We want to make sure that all of our exercises that we recommend remain within the so-called safety zone for shoulder instability. So here's an illustration that demonstrates the safety zone. So the examinee or the patient can safely perform exercises from 0 degrees of abduction up to and just shy of 90 degrees of abduction, and can safely perform exercises from 0 degrees of horizontal adduction, this is horizontal adduction, to 90 degrees of horizontal adduction. As adduction increases, that increases the vector load and would aggravate shoulder instability. As shoulder abduction increases, that also increases anterior forces on the capsule and would aggravate shoulder instability. So here's an example. Instead of the patient performing stressful behind the neck presses, which reproduce the apprehension position, he can simply position that in front of his neck. He can position his elbows closer to the side of his body, thereby minimizing the shoulder abduction and the shoulder external rotation, and can more comfortably perform shoulder exercise. Here's an examinee that shows his elbows way behind the plane of his body here. Although this is not a great diagram, and I wouldn't use this as an instructive illustration, but this is the best that we could find. It does illustrate that he's not bringing his elbows as far behind the plane of his body, although I still don't think his form is great for shoulder instability. What I would prefer that he do is I would prefer that he take and relieve these pins here and position these arms much closer and in a much narrower range of motion, so that not so much horizontal extension is required. Okay, and then one more example of training within the safe zone shows the patient doing behind the neck pull downs with shoulder in 90 degrees of abduction, full external rotation of the glenohumeral joint, and then he's attempting to bring his elbows down behind the plane of his body in order to clear his head. And here he's pulling. In other exercises we demonstrated pushing maneuvers, but even with pulling maneuvers, the stress on the anterior capsule in this position is tremendous, and it's a high risk maneuver. And I don't recommend this maneuver even for the healthiest of athletes, because this maneuver here provides exactly the same benefits, or nearly identical benefit, with none of the risk. So why not perform the maneuver in the same that gives you the same benefits, but why not perform it in a safer manner if it indeed gives you the same benefits? And I submit that it gives you the same or more benefits with none of the risk associated with this type of a maneuver here. Okay, so there's some exercise recommendations for patients with shoulder instability. Let's now talk about rotator cuff injury and rotator cuff surgery, and we'll finish up this section on shoulder rehabilitation.